Hey, can you guys unmute?
Okay.
Like,
Can you
I
all
can start
hear us
over.
now? Oops, it's okay. I just want to make sure there's no echo, but I think we should be fine. So, Karina's just going, you may have missed her objectives, but we're just diving right in, types of surgeries. It's fine.
Perfect. So you didn't miss much. I was giving a brief introduction of, my background and the objectives that we're going to cover. So just started with the types of spine surgeries that you might see. So anterior cervical discectomy and fusion. We do corpectomies, foraminotomies. You'll see posterior fusions and decompressions, whether that be cervical, thoracic, or lumbar. And also minimally invasive procedures. And then most recently endoscopic. Dr. Cashlin did a specialized fellowship in endoscopic, and he's been doing those more frequently. You might see these acronyms, ALIF, TLIF, LLIF, and DLIF, and this is just what they stand for. For a while, I think I just went through the motions of, oh, patient had a TLIF, and I didn't even really know what that meant. But so transforaminal is just the approach that the surgeon's taking to perform the fusion. Why do we fuse? Usually we're treating patients that have degenerative disc disease and loss of disc height, which is causing them either instability or pain. Some of our surgeons do deformity corrections for scoliosis or kyphosis. And primarily the fusion is to limit that motion that they're having that's causing them pain. We will, again, for instability, like if they have a spondylolisthesis, so when they're flexing or extending, their bones are kind of slipping forward or backwards on each other. And then we see trauma patients, fractures, and tumor resections. I feel like more commonly we've been doing ALIFs because they're better tolerated by patients. So if you think about it, a big surgery on the back, you're cutting through all of those thick muscles and it's super painful for them. So ALIFs seem to be much better tolerated by the patients themselves because you're not interrupting all of those muscles. So we will do these primarily for patients that have disease at L5, S1, and sometimes at L4, L5. And then that is also a surgery that's done in combination with the general surgeon for exposure, because we're going in from the front and they need to kind of move all the contents of the abdomen out of the way. Those patients are, though, at higher risk of bleeding and of an ileus. So you might see that they come in and they've had a bowel prep for their spine surgery, and that's why. I just provided this picture because I thought it was kind of helpful for just seeing. I use this a lot when I'm educating patients in the clinic of kind of what's going on in their back and what we'll actually be doing in surgery. So you can see here that the area of herniation is typically causing some sort of compression on the exiting nerve root, which is then causing them either back pain or shooting pain down their legs or their arms. These are just some pictures of in the surgery. So the first picture is minimally invasive. So those patients will come out with smaller incisions, smaller dressings, because we're using this tubular retractor under the scope so that you don't have to get quite as wide of an exposure. And then the second picture is endoscopic. So that's an even smaller incision. And so those patients have really been tolerating that procedure well, because there's just minimal disruption to all the other structures in the area. And then just kind of talking a little bit about what each surgery means. When it's booked a certain way and your patient comes out from the OR, all the different kind of acronyms that we use. So anterior obviously is from the front, posterior from behind. Usually when we're talking about a decompression, we're talking about either removing the lamina or making a kind of a hole in the neuroforamen to widen that area to give more room to the exiting nerve roots. So you're basically decompressing those nerve roots. Fusion we kind of have talked about. So it's usually when you're joining two or more vertebral bodies. We use supplemental bone. And then if it's an anterior approach, the surgeons are going to be using plates and screws. If it's a posterior approach, then screws and rods. Inner body. So the previous slide when we were talking about A-lifts, T-lifts. So inner body just means removal of a disc and replacement with a cage. And then a corpectomy is actual removal of the vertebral body to decompress the spinal cord. We will often use the patient's own bone, which is called an autograft, and or cadaver bone, which is called allograft, and then the various types of bone stimulants like BMP, so bone morphogenic protein is used. And then sometimes patients will ask, probably not right away in PACU, but we do get patients that ask, can I get an MRI? Like, can I go to the airport and go through the screening? Am I going to alarm? So we use medical grade, either plastic or PEEK implant or titanium. So it's MRI safe. It's going to cause some streak artifact, but it's safe for them to go through an MRI with their hardware.
If it's not the
patients that we typically try to identify pre-op that are high risk are often those patients that are having fusions of more than 4 to 6 levels. If we're expecting that their surgery is going to be a long case, so obviously the longer that they're under general anesthetic, the higher the risk. We, at the beginning of the procedure, try to predict the amount of blood loss we're going to have. Sometimes that's grossly underestimated, but that can then lead to hemodynamic instability. If we're doing a combined approach, so oftentimes intra-op, the patient will either start anterior and then flip the patient to posterior or vice versa. And so just the element of doing that adds some complexity.
Is that very common to do both?
Mm-hmm. Yeah. Staged procedures. So sometimes patients will be scheduled for a staged procedure, meaning that, on day one, we'll do the A-lift and the anterior portion, and then bring them back, allow them to recuperate for a couple days and bring them back and do their posterior portion or vice versa. Age, of course, and then there are multiple complex comorbidities that a lot of our patients have. So why do we restrict some of our spine patients' mobility? Really, I can't think of many situations where we're restricting their actual mobility. Like, we want them to get up and get moving and out of bed as soon as possible. But for our fusion patients, we need to immobilize their bones so that they can fuse. So your patients may or may not come out with their cervical collar on. I don't know how often you guys put them in it or if they roll out with them on, but the reason for cervical fusions needing collars are to allow limited range of motion in their neck to allow their bones to fuse. So I gave a similar presentation to the nurses up on the floor because a lot of times what we encounter is their apprehension to get patients up and moving right away. But just because they're in a brace or because they're waiting for a brace doesn't mean that they are bedbound or that we don't still encourage early ambulation. We do ask the patients for at least the first 6 weeks to avoid bending, twisting, pulling, pushing. We say about 10 pounds. So a full gallon of milk is 8 pounds. So when I'm doing my teaching pre-op or when I was inpatient and discharging patients, that's how I would describe it to them. And really, we want them to take it easy for those first 6 weeks, because during those weeks, they're at the highest risk of hardware failure, reherniation. So we want them to just take it easy. I just kind of put this in there. If you think about when patients are in braces, it's similar to when we break really any bone in our body. It's casted to immobilize it, to allow the bones time to grow back together. And it's the same thing when you're trying to fuse a neck. It takes a bit of time and often a lot longer, but that's why. Again, just reiterating that patients can get out of bed as soon as possible. They do not need to wait for PT to see them. And very often they do not need to wait for their brace to arrive. So for our big lumbar, thoracolumbar cases, you might see that they need a TLSO brace, an LSO, a corset brace. So those come from orthotics, and I mean, oftentimes they're not even delivered the day of surgery. They're being fit while they're inpatient. So we don't want patients to stay bedbound until they get their brace. We want them up and moving. Some cases that you might see patients who we want to keep on flat bed rest or not to get up are those patients that suffer from a durotomy intra-op. So a tear in the dural lining that puts them at increased risk of spinal fluid leak. So the surgeons oftentimes recognize this when it happens intra-op and repair it. But there are often cases that the surgeon will keep them flat for 24 to sometimes 72 hours to allow that area to heal. And it's basically taking the pressure off that area to allow it to heal. So unlike some of our patients that are on flat bed rest that can go in reverse Trendelenburg, these patients we want to remain their head level with their heart. So keeping their head of bed flat.
If they do have to get up and pack you, do we need to log roll them that they're not raised?
No,
Just to really minimize twisting.
not like a true log roll where you're, holding their neck, but, maintaining as much of, good spinal alignment as you can. They can still bend their knees and things like that. To brace or not to brace is largely dependent on the physician or the surgeon. We have a handful of surgeons that brace most of their patients, but then there's some that do not. So oftentimes they'll consider things like the quality of the bone. So if patients have softer osteoporotic bone, then more support is necessary. So you don't want the hardware pulling out of the bone right away or at all. The brace is likely to be more restrictive in that case and ordered to be on at all times. It's pretty rare that patients will be kept in braces at all times, but there are occasions where we will get them an extra set of pads because we do want them to keep it on at all times, shower with it, and then swap it out. The level, the number of levels, and or if you're crossing a junction, so the cervical thoracic junction or the thoracolumbar junction, you're often going to brace those patients. And then also compliance and feasibility of the patient. I mean, we kind of know our patients that are going to adhere to our restrictions and or not. Again, I guess I really tried to hit this home that it's okay for patients to mobilize. And then not many fusions or really any require 24-hour bracing, but fractures will. I included spinal hardware because I think, like I said here, pictures are worth 1,000 words. You hear about all of the products that are used intra-op, and I think it's just helpful to be able to see and and put a picture with the name. So the first picture is a cage, so metal that's then packed with either the patient's own bone or the artificial bone that takes place of the disc space that's removed. The second picture is a pretty large scoliosis correction. Can't really tell, but there's huge rods and then screws. The rods are just kind of a metal cylinder that help the spine stay stabilized, and they can be cut, they can be bent, they can, the surgeon kind of looks at the imaging and appropriately bends them with the devices that we have intra-op. Crosslink connects the long rods left to right and adds more stability. And then plates are used, like I said, in the anterior cervical approach where rods are not. So it's a plate and screws. We have a handful of different companies that we work with. I don't know how often you guys would interact with them, but I'm sure you see them walking around in their red jumpsuits. Just more spinal hardware. So screws get bigger as the bone gets bigger. Anterior screws are pretty small. The bones are smaller. It's closer if you're going from an anterior approach, closer to the bone. Posterior screws are set screws that the screws are placed within the pedicles, and then the rod is placed, and then the top of the screw to hold the rod in place. I would say that during the pandemic, we saw, at least when I was inpatient, we saw a huge change in our wound closures because we were trying to avoid patients needing to come back to the clinic for staple removal, suture removal. And that's kind of stuck. And I think it's good for patients. They don't need to come back to the hospital. Some patients live 4 or 6 hours away. So we're using a lot more Prineo, which is that clear tape dressing. We're using more surgical glue and absorbable sutures. So, some of our patients then aren't being seen until 4 or 6 weeks after surgery versus the 2. Showering. So if you're discharging a patient home, oftentimes that's the biggest question is when can I shower? So we usually want the patient to wait 72 hours before they do shower, but we want them to shower. So they can take their dressing off at day 2, but we don't want them to submerge in a bathtub or pool or anything like that. But showering, yes. We want them to wash around their incision, not aggressively, but allowing soapy water to kind of run over their incision. We've had patients that have come back to clinic that haven't showered since they've been discharged. And it's disgusting. Obviously, it's disgusting. So just reiterating to your patients that yes, we do want you to shower. It is okay to get your incision wet. Please keep it dry, keep it uncovered. Don't put any ointments or creams on it, but please shower. Some complications that you might see post-op. I would say probably the biggest one is a hematoma formation. And you're going to be the first ones to catch that. You are there at the bedside, you are monitoring the patient, and as they're starting to wake up, you're going to pick up on that new deficit. So it's really important to know what their pre-op exam was. Whether, I'm really not sure how it works down here, like if you're the person that sees them before and after or not, but getting good sign out from the nurse that had them in pre-op, or asking the surgeon, because they will be seeing the patient, either the resident, the attending. If it's me, I try to get a pre-op exam just so that you have a good baseline. And if there's any question, you can always go back to the pre-op notes, the clinic notes, but it's always good to kind of talk to the person that saw them before surgery. Intraoperative durotomy, we talked about, it's the dural tear. Those patients may or may not be on flat bed rest. There are sometimes that the patients will end up with a lumbar drain, which I know are kind of few and far between that you see those. So sometimes it's, you have questions or concerns, and you can always reach out if you ever want, you know, an in-service on that or more information on lumbar drains, because I know they can be complex. Neural injury, again, resulting in weakness, you're going to pick up on that. Anterior approach for the cervical discectomies. Those patients can have difficulty swallowing post-op, especially the higher up that they're being operated on. So if you pick up on that, you know, it's do a proper, you know, swallow exam and make sure that they're not choking. And if they are, just keep them NPO until they can be formally assessed, and let the physician know. Adequate pain control. You guys are really good at controlling post-op pain, but these patients are super, super painful. So oftentimes we will order PCA pumps to be started post-op. And then of course, respiratory complications. You know, you've got anesthesia down here, but oftentimes that can be an issue too. Bleeding, I would say when I was an inpatient NP, I got a lot of pages about bleeding on the dressing. We expect to see some blood on the dressing. I think when we get concerned is when it's completely saturated, like oozing out of the dressing. In that case, you know, I would want the surgeon to be made aware so that if they feel necessary, they'll pull down the wound dressing or the surgical dressing and take a look and see, you know, maybe we put too much space between staples, or maybe they do have a hematoma forming. And then also JP. So right after surgery, and I would say probably for the first 24 hours, expect to have high JP outputs. That's why we leave them in place. We want them to put out, you know, we don't want that blood accumulating and causing a hematoma. So we put the JP drain in there to avoid that. If you are emptying it, I mean, like an excessive amount, you know, it's filling up within seconds, minutes, that would be concerning. But high JP outputs are quite normal 24 hours after surgery. Neuro exam. So this is one of the biggest things you do for post-op spine patients. So it's important that you're checking each muscle group individually and keeping in mind what surgery they had. Checking deltoids, biceps, triceps, hand grip, their wrist extension and flexion, and hand intrinsic is going to be important for your cervical patients. And then hip flexors, knee extension and flexion, and plantar and dorsiflexion for your lumbar patients. I did put in some pictures that I think are helpful. So the grading scale for assessing muscle strength. You know, a lot of times a post-op, or not post-op, but just a neurosurgery patient is admitted to the floor for spine surgery, and the nurses are doing just like orientation questions and checking for a drift. It's not the most appropriate neuro exam for a spine patient. You want to be assessing individualized muscle strengths to pick up on any post-op complications or deficits that might be new after surgery. This is just another kind of small but illustration that's noting the dermatomes and myotomes, which is helpful. I found it super helpful in showing patients in the clinic, just so they know, like, this is where your lesion is and this is why it's causing X, Y, or Z. So, you know, if your patient had a C5-6 ACDF, you know, making sure that you're checking shoulder abduction and elbow flexion and extension. And if they have weakness, letting somebody know, so that further imaging likely is what's going to happen. Further imaging is obtained. So notify the resident that's in surgery. This can usually be found in the post-op orders or in the brief op note. It's going to be important to notify that resident because they are going to be the most familiar with that case and what happened intra-op. Sometimes the neurosurgery resident on call will get paged, and they really don't know anything about that patient. They might know something or be able to help you get in touch with the surgeon, but I would say use that as kind of a last resort. If you are not getting any response and you're concerned, never hesitate to escalate to the surgical attending. And we want somebody to lay eyes on the patient. The inpatient floor team is available for patients that are being admitted up to the floor. But again, they're not going to be able to help too much. They haven't met the patient yet. They don't know too much. They may have not gotten sign out yet from the resident. So always start with the resident that was in the case. And then if you do pick up on any post-op complications, what are we going to do? Likely get some updated imaging, whether that be a stat MRI or a CT scan. And then the patient may or may not have to go back to the OR for whatever reason. That's all I got. Anybody have questions?
Any questions, right? What are the, I don't know, does anybody have any like most common challenges with these patients or anything you can bring up, or now's the time to like ask, like? I don't know.
I think the residents and the fellows are really good now to tell you, expect a lot of GP drainage. Because, you know, when you have abdominal surgeries or other surgeries where you don't have the output that you
Right.
need with some of the spine pieces, it does kind of give you a step back. And
Yeah.
they've been really good about saying, hey, 200 is okay, and or you expect a lot. So
Oh, that's good. That's good to know.
So thanks, that was a great talk. I think I think it's such a crucial part for patients when they're down here, and I think all the complications that you listed are happening. We've all seen them. Neurodeficit or airway compromise. So those are things that are really crucial. And you all put them up. So I think these are complications that happen often, but when they happen, it's like one of the most awful days of these patients' lives. And you all are the ones that are there to pick it up and deal with them. Before you go to the floor and things get worse. So I think that's such a crucial part in the recovery of the patient. So thank you all for all you.
Thank you. I was just gonna say, is there anything else that we need to do better to to set them up for the floor, you know, that you guys run into, like, you know, they're with us for an hour, 2 hours. Is there anything else that,
do you want neck circumference on your cervical
that's a good question.
patients? Or?
I would say most of the surgeons do. Do you? Yeah, I would.
The answer is
Usually for the first 24 hours, we'll get Q1 hour neck circumferences. So it's, you know, helpful just to pass that on to the
That's probably the
inpatient
one thing that
team.
I see that gets kind of lost in the sauce. Is,
Mhm.
Neck
is
circumference,
that
yeah.
you know, you don't always get that on the handoff that they want.
Sure, sure. And I have encountered actually recently some of the residents not knowing that they do that on the floor. And so talking to them about that, because sometimes it's just not ordered because they don't think that the floor is going to do it. But for your anterior cervicals, we for sure should be doing that.
You guys mentioned about a lot of pain, and we see that our patients have so much pain.
Uh-huh.
I had a patient one time, I don't remember what kind surgery, but he was having so much pain within the 30 minutes that was dropped off to my face. He was given like clonidine, fentanyl, morphine, and like magnesium. So then later on, we found out he was like smoking joints. For pain. So when do you guys tell them to stop those before the
Well,
surgery?
yeah, we certainly tell them we don't like to even offer, or most of the surgeons won't even offer to do surgery on somebody who is smoking nicotine. But marijuana, I don't know. I mean, I tell my patients to not be smoking it, but you're right. A lot of patients do use it for pain. I don't know. Do you have like a certain time frame?
Yeah, I mean, I think a couple of weeks, like 2 to 3 weeks would be good. Like, even if someone is on pain medications, I let them know. So even if our patient is supposed to be today, we cancel. I just told them to try to hold off. I'm taking a lot of pain medication. I know you're in pain because of just anything you take before desensitizes your pain receptors. So then it's really hard to control your pain post. I think in a situation like that, then the resident or the escalated to acute pain centers, maybe put them on a
Well, we were in PCA too, doc, and we were like pushing a lot within that time frame. So like, they said, so what do you take at home? So I reported in Tylenol, and then like when they were more awake, they said, oh, I use my water for pain too.
Yeah, they've shown that marijuana use increases your pain med performance afterwards.
Why
And
is
it's-
that?
I don't know the answer. That's great.
First question.
Sure, I'm not sure, but I'm sure it's desensitized. It's like it over makes your receptors not as receptive.
I would think so, just like chronic
Like, kinda
opioid
blocks
use
it
makes it
from-
tough for us to care for.
Yeah.
What kind of luck have you had with methadone with your long-term opioid use?
Like so.
Intra.
Intra.
Yeah.
So I know that one of the protocols now is that they give your dose and I think it's helped out a lot. So a couple of things that so you know.
Golden.
And that's a Suboxone too, though? Suboxone.
Suboxone and methadone are both
Six
successful.
I'm here at is actually giving dose of methadone before. We have regional blocks that we're giving a lot of lidocaine that lasts for, it's mixed with clonidine, so it lasts for 24 hours. So since we started doing this, things I've noticed, yeah, we still have patients like the one that you mentioned, but it's not as frequent as I remember at least a couple of years ago. So
Last week, I have two patients that had neurosurgery with Suboxone. And then like after I give that to them, I think it has like helped with their pain. So.
They were on it at home.
Sure.
Not
but
sure.
Yeah,
like,
usually they
most of
have to
them
be on it
have, like,
before. It's not
20,
something that we can just order.
Yeah.
Say again.
It's usually something that they're on. Suboxone is something that they're on pre-op. We won't start that post-op.
I thought it was like a new order. I don't know.
Mm-mm.
Probably an
Usually if they're
existing,
already been on it.
yeah. They just want to continue it so they don't stop that pain control there.
patients like we mentioned, recently, over the past year, I've had a couple of patients where it's a contractible pain, but then the pain service puts them on ketamine drug. That's one thing that is becoming more and more
Mhm.
common, it seems like, and what you all's experience has been, but it's been, life changing for some patients for sure. That, coming in on Suboxone, it's really hard to control their pain. It's something that
Great. All good information. Thank you, guys.
Yes,
thank
We
you.
appreciate it.
Thanks for your time.
Thanks all for zooming in.
I love that slide that says all the surgeries and like what
That's
they
good.
are. That was really good.
I think I got everybody